review of normal heart function, and then we're going to move on to what happens when things go awry. So over here you can see on the left side of the heart, which by the way, we're going to be talking about just left-sided heart failure today. I'm not going to be doing right-sided heart failure. So that's what I take care of is left-sided heart failure. So the oxygenated blood comes from the lungs down into the left ventricle over here. And when it squeezes, what's that called? Contraction or systole, because the top number in your blood pressure is the systolic. That's when the heart is squeezing. And then the bottom number is the diastolic, when the left ventricle is relaxed. So then what's asystole? Right, you're not getting that pumping action anymore. It's not just a line on the screen. It's an actual reference to something that's not happening there. So if we're talking about left-sided heart failure, there's two different kinds. How many of you guys in your clinical experiences have looked at echocardiograms? Everybody? Okay. So you might see in the echocardiogram they talk about the ejection fraction. That's the percentage of blood that is ejected from that left ventricle every time it contracts. So it takes in a volume when it relaxes, and it ejects a certain volume when it contracts, right? So in systolic dysfunction, that's when the muscle is kind of boggy and doesn't give a good squeeze, okay? In diastolic dysfunction, it doesn't relax enough to let enough blood come in. So if you look at your 5 and your 3 cc syringes, so if you've got a 5 cc syringe with a 30% ejection fraction, you draw up 5 cc's, how much are you going to get out? Quick math. 1.5. 1.5 cc's is going to come out. So you draw up 5, you got a 30% ejection fraction, 1.5 cc's is going to come out. What about your 3 cc syringe? If you draw up 3 cc's and you eject a 50% ejection fraction. Right. So you can have a good ejection fraction and still have heart failure. This is something that took me years to figure out. Because when I saw an echocardiogram that said ejection fraction greater than 55%, I'm like, well, what the heck's the matter with this guy? He's got a great ejection fraction. The fraction is not so much important as the volume. It's a problem of volume that's getting around to the rest of the body. So you can see here, it's either that you've got too boggy a left ventricle to get some oomph behind it, or your ventricle's too stiff to allow a good amount to come in. Now you guys said you like hands-on stuff. So anybody recognize what one of these is? Turkey baster. Turkey baster, that's right. But in the hospital, occasionally, I couldn't bring hospital stuff. All this is my personal stuff. In the hospital, occasionally you'll see like a tray that comes with a bulb syringe. Usually we're using piston syringes, right? What do you reckon this represents if I'm talking about a pump? Systolic or diastolic dysfunction? Does it have less oomph? If I took this out and squeezed some water, do I reckon I'd hit the ceiling? No. But if I used one of my flushes, it hits the ceiling pretty hard, right? So this would be a good example to think of when you're talking to your patient about systolic dysfunction. It doesn't have the oomph behind it to get the volume out. I don't know if you want to pass this around, but you're welcome to if you want to. Okay, dokie. I want to show you one more example that you can think of when you're talking to your patients about systolic dysfunction. So, left ventricular dysfunction. So this is systolic. I've got some whoopee cushions here. If you're not allergic to latex, feel free to volunteer to blow up a whoopee cushion. I've got 5 right now. No volunteers? Okay. Come on.
Josh gonna end up going up 5 if you don't get
That's okay. He can just demonstrate for everybody. So, what are both of these made of? Latex, right? They're both made of the same material. So, yeah, it's some work. Now you have to put your lips on there and go for it. Yeah. I tried this myself this morning.
I'm really intrigued that you know how to do it.
Yeah. I just powered through it.
Oh, God.
Okay, wait a minute. We gotta get the pro to come in.
Sabrina, here. Sabrina, you need a whoopee cushion? We won't make you share drums.
Oh, mine's sealed shut.
Whoopee!
There you go, yay!
Yay! Okie dokie. So, now, take a regular balloon and blow that. And, you know, how many breaths would you say that took to fill that? By the way, you get your choice. Thank you. Okay. So, look at the volume. Look at the volume between this one and this one. They're both made of the same material. So what would this represent? What could you say to a patient that this would represent? Diastolic dysfunction, because they're both made of the same material. This one allows a lot more in. How many breaths? Like 5 breaths. This one was filled up with 1 breath. So you can still have, 100% ejection fraction on this. You're still not going to get as much volume as you would with even a small ejection fraction on that.
Like 50 of this, including 1.
Right. Right. So if you see on the echocardiogram or on the cardiac cath report, ejection fraction greater than 55, don't think, oh, they're golden. I don't need to talk to them about fluid restrictions or salt or anything like that because they must be great. It doesn't mean that. Okie dokie. So, some of you asked specifically about causes of heart failure. Okay, so let's say that you've got a muscle that's working pretty good, and then it doesn't get the blood flow to one part of it, and that muscle dies off. Do you reckon that that muscle that dies off is going to contract as well as healthy muscle? Right. Also, if your heart is working against hypertension, if you've got a blood pressure that's running 200s over 100s, your heart is having to beat against that pressure, right? It never gets a break. Even in diastole, when it's supposed to relax, it's got all this pressure, right? So hypertension can cause heart failure because your heart is going to try to compensate for all that pressure by doing something called remodeling. You can also have valve problems. One of the biggest causes of heart failure is people who develop endocarditis. This especially happens in other countries where they don't have treatment for like strep throat. You get strep throat and it goes to your heart and it gets vegetation on the leaflets of your valves. In this country, usually you're going to get an endocarditis from drug use, IV drug use. The big one, it appears now, is Opana. People are injecting Opana, and they're not as clean as we are when they're doing injections, so they can get an infection that goes to their heart, and that can lead to heart failure. Cocaine can also lead to heart failure. Some people are born with hearts that just don't work right, and those are congenital defects. Okay, so there's a couple of different ways that when you're looking through a chart, you might see heart failure documented. Instead of them writing out congestive heart failure or heart failure, they might just write HFrEF. And that's heart failure with a reduced ejection fraction. So that means it's what kind? Systolic heart failure, right? Okay. And then diastolic failure, heart ejection with a preserved ejection fraction. There's some argument about whether preserved is the right word to use, but that's what they're using right now. So if you see this documentation, EF, what is that, less than or greater than? Less than 40%, what's that? Systolic heart failure. Yeah, greater than 55%. Right. If there's also some mention of other stuff. Somebody could have, I had a normal echocardiogram recently, and my ejection fraction is greater than 55%, but I also don't have diastolic dysfunction. LVFD. Systolic dysfunction. Right. Okie dokie. So I'm sure you guys already know these. These are probably, old school to you. But signs and symptoms of heart failure. If you talk to a patient and they talk about, I don't sleep in bed anymore. I sleep in my recliner. That's orthopnea. They have to sleep sitting up because they can't breathe when they're laying flat. That's called orthopnea. You might also see edema, swelling of the ankles. But there are other conditions that could cause either one of these. What's an example of something that could cause edema in the ankles or feet? Yeah. Lymphedema, kidney failure, pregnancy. So edema by itself does not mean this person has heart failure. Orthopnea by itself does not mean this person has heart failure. What's another condition that causes orthopnea? COPD, right. So those two, we're thinking along the lines of heart failure, but we could also be thinking along the lines of something else. Dyspnea with exertion. So like I climb one flight of stairs and I'm like,
I have heart failure. That was me this morning.
I know. That could also be COPD, right? Paroxysmal nocturnal dyspnea. You're sleeping fine and you wake up gasping for air or coughing a lot. There's something that can cause waking up coughing a lot. Can you think of anything that might do that? Yeah, asthma. Reflux. Did somebody say reflux? Yeah. You can develop that. So, because we are nurses or going to be nurses, it's not within our scope of practice to diagnose, right? So we have to wait for the physician to diagnose. But we can recognize by reading what physicians have written, this person has heart failure, and I need to think along the lines of those nursing skills that I have that I can help use to take care of this patient. So they can have a chest x-ray, and in the report you might see something that says vascular congestion or pulmonary edema. Echocardiograms, that's where they put the gel on the chest and they look at it just like a pregnant lady getting an ultrasound. So they can also have a cardiac cath, a mug scan, a nuclear stress test. There's a lot of different tests that a physician can make mention of an ejection fraction. But I will tell you, an ejection fraction is not really like one of those lab tests where it's very cut and dry, very objective. It's kind of subjective. One cardiologist might look at it and say, that looks like 50% to me. And then another one might say, nah, that's greater than 55. So, and some of them might say, that one's definitely systolic dysfunction because it's less than 40. Nah, I'd say it's more like 45. So if that's not a cut and dry, definite, like a hemoglobin or a hematocrit. Okay, so heart failure can lead to heart remodeling. And heart remodeling is what is really problematic with left heart failure. So with left heart failure, the heart tries to compensate for what is missing there. The body tries to compensate for what's missing. And what is missing when you have heart failure? We talked about it at the very beginning. The volume. You're missing the volume that's supposed to be going around to the rest of your body. The volume of oxygenated blood that's supposed to be arriving to your kidneys, that's supposed to be arriving to your liver, etc. So remodeling basically is kind of like training your dog, right? Like Pavlov's dog. Have you guys learned about Pavlov? Okay. So you ring a bell, they start salivating because they've kind of gotten used to the idea that when you ring a bell, there's going to be food. So your heart's like, oh, I'm working so hard. Well, I'm going to have to start doing such and such to work against that. So your body is training your heart to behave in a certain way. And I've got some things that I want to do to help you. The way that it's set up in here, we might just have to do it conceptually, but I really want to do it for real.
If you need to change, what do you need?
No, that's okay. I'm going to start with one thing first. So let's say that I'm running a garden hose, and I've got flowers over there that I want to get to, but the water is only coming out like this. What can I do to get the water over there? Right, squeeze the end of it, right? So that's one way that your body compensates for the lack of volume, that vasoconstriction, right? So your kidneys are saying to your body, I'm not getting enough output, I need some water over here. So it squeezes down. Now let's say I'm using my turkey baster with my systolic dysfunction, right? And I'm getting vasoconstriction, so I'm putting my thumb over the end of it so that what squeezes out will go a little bit further, have a little bit more oomph to it. But then, what's this part doing? It's working real hard to get this, because now I'm not only pumping with a less than stellar pump, I'm also pumping against afterload, against resistance, right? So, let's go ahead and do it. You guys said you wanted hands-on, so we're doing hands-on. Okay, so how many is all 16 here today?
Well, I think there's 13 right now.
Okay. Well, split up into 2 teams, and we'll do 5 on each team, and then some will be observers/cheerleaders. Okay. Okay. So 2 teams of 6 then. 2 teams of 6. Is that good? You said 13? 13. Okay. 2 teams of 6 and 1 extra on 1. Come on.
Go team!
And I would put your books away because this might get wet.
But where are we getting ready?
What's going in next? I mean, it's not going to be like, shooting all over the place or anything, but it's,
We'll clean it up.
We'll go slow so that everybody makes sure to get here.
What, like,
We'll basically, you're going to start off in a circle around here. How about that? Okay. So, you should have 1 more cup than you have people. So, go ahead and 5, 2, 1, 5. So the observer cheerleader doesn't have a cup. Did you guys find a good empty spot? Yeah.
Right.
One more cup, and then you actually have it. Okay, so everybody have your 5cc syringe? No. Get your 5cc syringe.
Will they need 3 also, or just 5?
Just the 5. Okay. We'll do it. See? Okay. Fill up each of the cups till the top line of you see where the ridges are? It should be 5 people and then 2 observers on one side, 2 cheerleaders on one side. Oh.
That's not saying.
James,
that's okay. Okay. We'll cheerleader.
Okay. No. So it should still be one more person in cup. So you need everybody needs 1 cheerleader.
I'll be a cheerleader.
Okay. But I'm sorry, 1 more cup than person. So you have 5 on your team. You should have 6 cups, but only 5 people are going to be doing the injecting.
So how many many people you have at?
We're good.
We're good, we got it.
Amanda's cheerleaders.
It's only 5 cups filled up.
No. It should be, I did the math based on the other numbers.
Sorry.
That's okay. That's okay. So if you've got 5 plus a cheerleader, then you should have 6 cups, but your cheerleader does not participate in the.
So
one more cup. So does anybody else need any more water?
Go teams.
Okay, there. So, what we're going to do is we're going to play and we're going to demonstrate regular heart function, okay? So each of you is kind of a part of the circulatory system. And the drawing and putting back will represent the heart pumping the blood around, okay? So I'm going to demonstrate over here. You're going to draw up from the cup to your right, 5 cc's. And you're going to inject in the cup to your left, 5 cc's. You're not going to mess with the cup that's right in front of you. And there will be 1 extra cup.
Draw up from the right.
Draw up from the right into the left. Don't mess with the cup that's right in front of you. Okay?
Broncos. Good team, go. I was gonna say, Amanda, I hear Sekola over here. I don't hear.
Okay, so what we're gonna do is we're gonna do just a few rounds, and we're gonna work together as a team. Okay, you don't want to be one person going faster than the other because we're doing normal heart function right now, right? So we're gonna say draw and squirt. Ready? Okay, squirt. Okay, all together. Ready? Everybody, that's right. The cheerleader needs to get involved. And then draw and squirt.
We're all ready to begin.
Draw
From your right.
and squirt.
Josh, you gotta squirt with them. You gotta stay in rhythm. Y'all gotta draw it up together and squirt it together. Oh, good job.
Okay, good. All right. Now I'm going to make it a little bit harder for you. Make it a little bit harder. Okay. So where's the extra cup?
Oh, yeah, so we only have 45 cups.
I don't know. Oh, okay. No. Each of you has a cup in front of you, right?
This is technically
So that's your extra cup. Okay, I want you to fill that to the brim. Yeah. Okay. Okay. Where's your extra cup?
That's my cup. Yeah.
Because she's gonna overflow.
Did y'all make a mess? You did.
Not
Okay, no, you're fine. I'm just gonna go get you a paper towel.
So here's the trick. You can't let this one overflow, right? What do you reckon that represents?
That's your tissues.
It's fluid overload, right? Because I've just added too much fluid to the system, right? So that's what happens when someone is in heart failure. So now you guys are going to have to work together again and do your draws and squirts. Okay? So we'll go for. I don't have a.
What do you want to do?
Yeah, can we go for 30 seconds?
Okay, hang on, guys. I'm slow at finding this.
Okay. Wait a minute. You just let it start. Everyone's ready to spurt.
Alright, are we ready?
Yeah. Okay, ready? Go.
Let's draw. And then we got the
There's still somebody next to me. How's that cheerleading going?
No,
Stop.
Okay, how did that work out for y'all?
Great.
Okay, now the extra cup we're gonna dump it all off because I don't wanna make a big mess. Share some of the extra cup among the other cups. So that every cup is equal again. Okie dokie. Now who's got the extra cup? We're gonna need to make some room probably. Where's the extra cup? Okie dokie. Hand that down. Actually, we're gonna put it on the end of that table, up on that ledge.
Up on the ledge.
I don't want to follow mine. Are we doing this one?
I need access.
It's going to be further away.
Part of the process.
Yeah, that's good. Okay, where do you want to? So, how about you
She's
put
gonna have to draw
your
and you
like
have to put in
behind you, so you have to.
I have to put into it?
Like,
Yeah. It's just further away.
You better do it. So bring them upstairs.
They both need
it.
it.
In the middle.
Oh, yeah. It needs to be far away from you, but not necessarily far away.
Should we put like a chair or something?
I'll reach it.
Jody, you
That's fine. You can put it right in the corner.
I don't want to do that.
Don't shoot at each other. Okie dokie. So if I put that, well, actually, I tell you what. Let's go ahead and do the 30 seconds, and you guys tell me what you think. And here's the thing: the team that can move the fastest. So cheerleaders, this is where you guys come in, okay? It's whatever comes from the court. We're still doing the same thing. We just moved one cup further.
Move this chair.
Okay.
No problem.
Okay, so cheerleaders, remember that the name of the game is as fast as you can, okay? As fast as you can. All right, 30 seconds. Here we go. Go.
Now we're about to twirl.
Faster. Faster. That's still so close, though.
Because they were so perfect while we
It's the personality. Okay, stop. Okay, so now if this has been set up a little bit differently, the other person was gonna have to like run to do the squirt from the far away.
they were so close.
We should have put them both over there.
Okay, so yeah, except that then you guys would have been climbing over each other and been like a game of spoons. So what do you reckon putting the cup farther away? Are you having to work harder to get it there? Okay, so that would be like your vasoconstriction, your afterload, right? When you put it closer, that's like taking a medication that makes it easier for your heart to work against that, right? What's the cheerleader's job here? What's the cheerleader doing?
The rhythm together.
Right. That's great. That's great. But the other thing too is that the cheerleader was really supposed to be urging you to go faster, go faster, go faster. Okay. I think this team they kind of cheated by moving it away. Look how fast
It's not cheating. It's strategic planning.
Okay. So this team was a little bit faster. In your body, what's making your heart beat faster? That's one of the things that we're trying to get not to happen. Because do you reckon you could do that all day long? No, that's exhausting work. And imagine if you've got too much fluid and too much vasoconstriction, you're making your heart work very hard, right? So now we're going to talk about medications and how they work to make sure that doesn't happen. So heart remodeling. Thank you guys for indulging me. I'll clean up. So heart remodeling is basically your body's response and your heart's response to the extra demands that are placed upon it, right? So one of the things that can happen is your heart beats faster. So it can be either like like a response in each cell, so that each cell would get bigger, or your heart stretches out, or your heart beats faster, or vasoconstriction happens. So all of those are examples of remodeling. Now, remodeling can be good. If you go faster, yeah, you're going to get that volume delivered. But you can't keep that up, right? If you want to get, water back to the back flowers and you vasoconstrict, that's great. But if somebody's pumping that water behind, that's a lot more work for them to get that water to those flowers. You're going to do it in the short term. So remodeling can be good in the short term, but it's not good for the long term, because that remodeling has consequences. And so your heart beats faster, and then because it's now exhausted and still not putting out enough, your body's like, go even faster. So it's good in the short term, but in the long run, it's not good. So medications for heart failure. The first thing you want to do is you want to get the fluid off of them. And so you'll give, the physician will order like IV Lasix or IV Unix if they're in an acute exacerbation. If they just have chronic heart failure, they might be taking Lasix pills, okay? Now, if somebody has hypotension, let's say that they've gone into septic shock or something, and so they've developed hypertension, we don't worry so much about people with heart failure getting fluid overloaded in that case, because we can treat that later with Lasix, but we can't treat a dead person for heart failure because they're dead. So occasionally you might say, oh my gosh, this person's in heart failure, but they're running their fluids at 150 cc's an hour. That's crazy talk. Well, it might be, but do some critical thinking. Are they running those fluids fast because something else is going on? And then you can fix that later with Lasix. Okie dokie. So your ACE inhibitors, your trills, right? That works by saying, okay, we're not going to have that cup so far away. We're not going to make you have to work so hard. We're not going to put that thumb over the garden hose. We're going to relax everything, which might be in the short term not so great, because remember, that was a compensatory mechanism, right? But in the long term, it's going to preserve that heart, and it's going to keep that remodeling from happening, okay? So ACE inhibitors is one of the things that you'll see, particularly for systolic heart failure. There's not a lot that can be done for diastolic heart failure. There's not a lot of evidence-based stuff other than keep the fluid down, right? But for systolic, which is where you've got that boggy kind of pump and that enlarged heart that's got thin little walls, there's some stuff that you can do. One of them is an ACE inhibitor. So if you see an ejection fraction of less than 40%, you're looking for that prill. Now, what are the problems with prills? What's something that cough and angioedema, right? So if somebody can't handle a prill, an ACE inhibitor, then you go to the ARBs, angiotensin receptor blockers, okay? So those are the sartans, right? So that one's not the gold standard, but it'll do in a pinch kind of drug. Your gold standard is your ACE inhibitor. But if you can't handle an ACE inhibitor, then you go to an ARB. Now, why might you not be able to take either one of those? Renal insufficiency. If you've got kidneys that aren't working either, you can't really be loading up a bunch of stuff that will stop that RAAS, that RAS mechanism. Because your kidneys can't swing and stuff like that. Now, evidence-based beta blockers. I'm going to talk about evidence-based stuff here. So why do we do the things that we do? We do the things that we do because we have evidence to show that we should. For example, it might be nursing lore and nursing tradition that we, open the windows and let a lot of light in. But there's actual proof that letting light in and exposing people to fresh air is good for them. So otherwise, we would just be doing it for tradition's sake. But we actually do those things because there's evidence to prove that it works. anything that you do, there should be some rationale behind it, some evidence-based rationale, not just because, I feel like it today, or the patient asked me to. There should be some evidence behind what you're doing. And at Cape Fear Valley, we have 2 evidence-based beta blockers. And the beta blockers, can you imagine what that function is? If the ACE and the ARB relieve the vasoconstriction, what does a beta blocker do? And think of the pumping and squirt, the drawing and squirt. Slows it down, right? Because you can do this all day. But can you do this all day? No. So imagine if you're carrying a backpack full of water bottles, and I put you on a treadmill that's going up at 30 degrees at 5 miles an hour. So your ACE and your ARB is lowering the ramp so that you're going straight instead. That makes it a lot easier. Your beta blocker takes it from 5 miles an hour down to 2. And then your Lasix makes you take the backpack and water off. Okay? Almost made another big mess. Okay, so I already told you what all of these do. So which medication reduces the volume demand? Lasix. Which medication or medications reduce the resistance against the heart? ACE and ARB. And which medication prevents heart fatigue? Gotcha. Okie dokie. So in your pre-assessments, you guys told me that you know all about how to tell patients how to take care of themselves. So if you look at your little cards, A is yellow. Go ahead and put your yellow out to your left. Okay, B is pink. Okay, C is green.
What was B? I'm sorry.
B is pink. And D is orange. Okay, so when we go through these, you're just going to wave your card for your answer, okay? So, the American Heart Association recommends that heart failure patients should consume no more than blank milligrams of sodium each day. Is it A, 1,000, B, 1,500, C, 2,000, or D, 2,500? Wave it so I can see it. Okay, it's actually B, 1,500. And here's a little hint. Not just for heart failure patients. The American Heart Association recommends that for everybody.
Google was definitely wrong last night.
Here's the hint. We can't lower it at the hospital because of patient satisfaction.
Well, that's what I would call it.
Yeah, no, I agree. In the orders, you'll see a 2-gram sodium diet ordered for heart failure patients. We would get it down to 1,500. Except that they can't figure out how to do it and not have patients complain about it. They already complain about hospital food. I mean, because when you think about it, here's an example.
In our teaching, I mean, I thought everything we learned in our teaching is always 2 grams of sodium.
Right. The American Heart Association recommends 1,500. Right. Now, I know that the old one was 2 grams, but 1,500 brings it down another notch, and that's the current recommendation. Remember how we're talking about
evidence? And that's based on evidence.
Right, I was about to say, the evidence-based stuff. So that's the most recent recommendation is 1,500 milligrams.
Let me make one point real quick.
Yeah.
Your textbook is literally 4 or 5 years old. But what I care about is that in Clint's world, it's going to be 2 grams.
Yeah, I doubt that they're going to get that
Tech's
specific.
world, it's not going to narrow down because they're going to make sure it doesn't narrow down to a conflict between evidence-based practice and textbook. Okay, so if you see 2 grams, you're not going to see 1,500 as an option. So if you only see 1,500, then that's what you need to. Okay.
1,500 or 2 grams, either way, that's a lot less than the typical American consumes each day. I'm a student just like you guys are. Tell me what you typically eat for breakfast and for lunch each day.
Piece toast. They're pretty good. Yeah,
Well, that's good. As nurses, you should model good behavior and the picture of fitness yourself. I've been driving up to Chapel Hill for class. So usually I get out of work, and then I drive up to Chapel Hill, and then I get out of class, and the only thing that's available to me is fast food. I mean, yeah, I'm sure there's like some healthier choices, but it's kind of hard to eat a salad when you're riding down the road. You know, I could stuff right in my face. So that's something that's difficult too, not just for college students, but also for older people. Think about what's going to be available to them. Are they going to be whipping up big, giant Bobby Flay meals, or are they going to be pulling something out of the freezer or something out of a box, or going to K&W? You know. Okay, so the next thing, most sodium in Americans' diets come from restaurant foods, salt shakers, canned soup, or frozen vegetables.
Oh, sodium. That's like
Okay, 70% of American salt consumption, sodium consumption, comes from restaurant food. Yeah. And here's the thing. Restaurants want their food to last a long time, right? Because that's inventory control. That's money. A lot of foods that were developed to last a long time were actually developed for the military. Think of MREs. Those things last forever. Right. But they're preserved. People used to fight wars over salt because salt preserved food. And if you had a steady food supply with preserved foods, then, you know, your society was going to be all right. Well, now we tend to always consume preserved foods. Patients should do what daily in order to monitor their heart failure? Okay, most of you got this right. Weigh themselves. They should weigh themselves. If you gain 3 pounds in a single day, 3 pounds or more in a single day, or 5 pounds or more in a single week, that's probably because you're retaining fluid. It's probably not because you had a big meal. I mean, think about it. This is a half a liter of fluid. This is probably, you know, a pound and a half by itself, right? So fluid can weigh a lot. And that's probably the only thing that's going to weigh that much that fast. So more than 3 pounds in a day or more than 5 pounds in a week, you need to call your doctor. Okay, patients with heart failure should eat sea salt instead of regular iodized salt because yes. It's because they should not. Sea salt is the same as regular salt. Both of them, NaCl, both of them contain 40% sodium, right? So if you've got a half a gram, no, we'll just make it easy. So each of these packets is a half a gram, right, of salt. So that's 1 gram of salt. So that's 400 milligrams of sodium. Okay. So even though I use salt and sodium kind of interchangeably, I do that because when I'm talking to patients, I'm not giving them the, you know, chemistry lesson about it's NaCl. It's to them it's salt, but on the packaging you'll see sodium listed, not salt. So I've already given you the answer to that one. B, 40%, right? Okay, so if you look at this sheet right here, which is what's handed out to you. This is something that we generally send to skilled nursing facilities, but I'm going to switch it up for you for patient self-management, so that when the patient leaves the hospital or your care, now you're giving report to them about how to take care of them. You guys give reports to each other when you're changing shifts and handing patients off. When it's time for that patient to leave, you need to give report to them so they know how to take care of themselves. So instead of weighing the patient twice a week in the morning, the patient should weigh himself daily at the same time of day, wearing the same kind of gear. So I usually recommend to people, they get up, they pee, they weigh themselves, they write it down. Okay? Then the next day, they get up, they pee, they weigh themselves, they write it down, and they compare those two numbers. More than 3 pounds in a day, more than 5 pounds in a week. That means it's time to call the doctor. Sometimes patients will say to me, I stopped taking that medication because I was feeling better. Well, that's like not paying your electric bill because your lights are on today. Your lights are on today because you paid your electric bill before. So you're feeling good today, patient, because you took your medications. If you don't continue to take your medications, you won't continue to feel better. Am I running out of time? Is that what I'm doing? Oh, sorry.
That's okay.
You can tell
We
I'm
just have
not
another
excited.
class coming in.
Okay,
They gotta get to another class.
so exercise as much as tolerable. Avoid these salty things. The salty six. Does everybody know how to read labels? Sodium labels. Okay, so frozen peas have a lot less sodium, 125 milligrams instead of canned peas. Can you rinse off the canned peas and get rid of the sodium? No. It absorbs in there. That's what preserves it. Otherwise, you'd have rotten peas in salt water. Okay. Fluid restrictions. They might get thirsty because they're on Lasix. They'll feel wrung out like a rag. Tell them to suck on frozen fruit. Don't suck on ice because that's still liquid. And you're going to have to teach your patients about where their sodium is coming from. Okay. Some people had asked me about surgical interventions. Sometimes we send people home with a life vest, which is an external defibrillator because